Hello everyone. Me, Dr. SK Madhukar, consultant pulmonologist, Madhukar's Clinic and Lung Hospital, Patna, welcomes you all. It's my absolute pleasure, privilege, and honor to be here with all of you. And not long time ago, we considered bronchiectasis an orphan disease. And with its increased recognition, the prevalence of bronchiectasis kept on increasing. And today, when we are sitting together, the bronchiectasis has become the third most common chronic lung disease after asthma and COPD. And I thank CCI, Chest Council of India, to bring this important topic into the discussion at this webinar. So I thank the founder trustee, Dr. N.H. Krishna, Dr. Narayana Pradeepa, President Dr. Ashish Dubey, Secretary Dr. Anil Maske, Webinar Coordinator Dr. Vijay Chanam Chetty, Scientific Advisor Dr. Shivani Swami, and Dr. Atri, my good friend who personally invited me for this webinar. I have a brilliant set of panelists with me sitting together. And I'm really honored to introduce them to all of you. Dr. Mohan Venkatesh Pulle. He is a consultant thoracic surgeon, Institute of Chest Surgery, Medanta, Gurugram. Dr. Koushik Muthu Mathiwana. He is Director Lung Clinics, Head Department of Respiratory Medicine, Sri Muthu Kumaran Medical College, Chennai. Dr. Shweta Bansal. She is the unit head and senior consultant, transplant pulmonologist, pulmonology and sleep medicine, Artemis Hospital, Gurugram. Dr. P. Swati, senior consultant microbiologist, head of laboratory and transfusion medicine, Yashoda Hospital, High Tech City, Hyderabad. And Dr. Aparajeet Kar, consultant pulmonologist and critical care medicine department head, Green Hills Hospital, Silchar. So I welcome you all. And before the panel discussion, the program is designed in such a manner that we are going to have two talks. The talk would be dedicated initially about the diagnostic roadmap and also the long-term management in bronchiectasis. And the second talk will be the role of surgery in bronchiectasis. So I would first invite Dr. Koushik Muthu for his talk on the roadmap from diagnosis to long-term management in bronchiectasis. So Dr. Koushik Muthu, please.
A very good evening to dear panelist and moderator. I thank CCI for this opportunity to invite me to deliver this lecture on clinical management of bronchiectasis. So today we'll be seeing the clinical management of bronchiectasis, a comprehensive clinical review, in which we'll be discussing about the epidemiology, diagnosis, airway clearance, antimicrobials, exacerbations, and monitoring. I am Dr. Koushik Muthu Mathivanan, professor and head at Sri Muthu Kumaran Medical College, Chennai, and also the founder and director at Lung Clinics and Chennai Institute of Pulmonology. So what is bronchiectasis? Bronchiectasis is a chronic structural lung disease characterized by permanent abnormal dilatation and destruction of the bronchial walls, resulting from a self-perpetuating cycle of infection and inflammation. So the pathological hallmark here is irreversible bronchial dilatation with wall thickening. The classical triad includes chronic productive cough, recurrent infection, and dyspnea. The radiological standards include a high-resolution CT scan in which the broncho-arterial ratio is more than 1, which is also known as the signet ring cycle. The prevalence is somewhere approximately 67 to 566 per 1 lakh adults, rising with aging population. The mortality driver in this subsector is progressive respiratory failure and, of course, pulmonary hypertension. Coming to the etiology and the underlying causes, there are multiple etiological factors, especially when you consider bronchiectasis. The predominant ones are the ones which has been listed here. The most common one is post-infectious, of course, pulmonary TB in our country, non-tuberculous mycobacteria, childhood pneumonia, measles, and pertussis, immunodeficiency syndromes like common variable immunodeficiency, X-linked A-gamma globulinemia, HIV-associated lung diseases, and obstructive lung diseases like COPD-associated bronchiectasis, foreign body or tumor obstruction, tracheobronchomegaly like Mohan syndrome. The genetic and structural causes include cystic fibrosis, primary ciliary dyskinesia, and alpha-1 antitrypsin deficiency. The inflammatory and autoimmune causes include rheumatoid arthritis, inflammatory bowel disease, and allergic bronchopulmonary aspergillosis. In spite of all this etiology, there can be a subset of patients who fall into the idiopathic group where the causative agent is not identifiable. And that belongs to 26 to 53% of cases, most common in older females, and typically the lower lobe predominance. Coming to the pathophysiology, it is basically the initial insult, which happens to be an infection, aspiration, followed by an obstruction or immune defect, followed by mucociliary dysfunction, where there is an impaired mucus clearance and bacterial colonization, and then there is an airway hyperinflammation caused by neutrophilic infiltration and protease-antiprotease imbalance, which leads to structural damage, causing bronchial wall destruction and irreversible dilatation. Again, this is a cycle which again leads to infection and obstruction, and the cycle continues. Coming to the clinical presentation, the main clinical symptoms of bronchiectasis are cough, expectoration, hemoptysis, breathlessness, pleuritic type of chest pain, and certain systemic symptoms can also be present. Cough is always productive and which is chronic and often worsening in the morning with mucopurulent sputum. And the sputum is usually purulent and purulent to mucopurulent to purulent, and it can be copious, that is more than 25 ml per day. And the three-layered appearance of the glass is the pathognomic sign of bronchiectasis. Hemoptysis can be mild to massive from the bronchial artery erosion. Progressive dyspnea can be present, which correlates with FEV1 and extent of the disease. And pleuritic pain is always due to the inflammation, or if there is an inflammation of the airway, or if there is any underlying pneumonia. The systemic symptoms can be fatigue, weight loss, and fever during exacerbation. Signs on examinations will be coarse crepitations, finger clubbing, cyanosis, core pulmonary and advanced diseases where there is elevated pulmonary artery pressure. And there will also be a concurrent VIS, obstructive airflow disease, in 70% of patients. So coming to the red flags, which symptoms has to be considered as the most crucial symptoms is the massive hemoptysis in a bronchiectatic patient, rapid weight loss and night sweats. You have to exclude TB and NTM in this patient. And new clubbing, which increases in grade, usually you have to do a malignancy screening. Coming to the diagnosis aspect, the high resolution CT thorax, which is the gold standard for bronchiectasis diagnosis as of today, can show signet ring sign as discussed previously. Can also show bronchial wall thickening, where the wall thickness is more than 1/10 of the bronchus diameter, lack of tapering of the bronchus. The bronchus is visible within 1 centimeter of pleura or abutting the pleura. And there can also be air trapping and mucus plugging, which is seen as stream bud appearances or V-shaped or Y-shaped opacities on expiratory cuts. The extent and distribution includes bilateral lower lobes in post-infectious, upper lobes in cystic fibrosis, and middle lobe and lingula in non-tuberculous mycobacteria. Coming to the HRCT pattern, you could clearly see this is the normal pattern, and this is the cylindrical bronchiectasis. This is a varicose bronchiectasis, and this, what you see at the fourth, is the cystic bronchiectasis. So, an illustration again, comparing the CT thorax, HRCT thorax, you could see this is a cylindrical bronchiectasis where you could see marked in the green color. And this is a varicoid type of bronchiectasis where you could see marked in the blue color. And this is a classical cystic bronchiectasis, which is marked in the purple color in this patient. Also has a layer of pneumothorax, probably due to rupture of some bulla or a bronchiectatic complication. So this is a signet ring sign which we discussed. This is the traction bronchiectasis. And this is the non-tapering of the bronchi, which is seen up to the periphery, up to the pleura. And this is mucus plugging seen in certain conditions. So how will you work up for a bronchiectatic patient? The diagnostic workup usually includes identifying the the diagnostic workup is usually done to identify the cause of the disease. So stepwise, we will do a microbiological examination in which the sputum culture and sensitivity is done, including AFB smear and gene expert for MTB, induced sputum if unable to expectorate, bronchoalveolar lavage for culture negative cases, and definitely NTM culture in certain subset of patients on three separate days. Coming to the genetical and structural diagnostic workup, we will do a CFTR mutation, especially if there is upper lobe involvement. Nasal nitric oxide, if you're considering PCD screening, which should be low in PCD. TEMs of nasal cilia, which with genetics or DNA I1, I2, and DNA H5. Alpha-1 antitrypsin level is also a subtype phenotype which you would like to evaluate. Coming to the immunological aspect, we will do rule out hypogammaglobulinemias, and then we will do a specific antibody responses for pneumococcal and tetanus. And the third one is the most important, which we come across a lot these days, which is serum IgE, and along with Aspergillus specific IgE, the ABPA screen. You will also do a HIV serology. And once the diagnostic workup for identifying the cause is over, then you will do a workup for the functional status of the lung with the following tests, which includes the spirometry, which includes lung volumes with DLCO, and you will definitely do an exercise tolerance test either with 6-minute walk test or CPET, and a sputum rheology or mucociliary clearance, which is still in the research stage. So coming to the severity assessment, we have two important scores. One predicts to predict the mortality of the bronchiectatic patient, which is the bronchiectasis severity index and the Facet scoring. So the bronchiectatic severity score includes 8 parameters: age more than 70, FEV1 less than 30, more than 3 exacerbations in year, MRC dyspnea scale of more than 4, Pseudomonas colonization, other colonization, radiological severity, and hospital admission. And the score is divided into 0 to 4 as mild, 5 to 8 as moderate, and more than 9 as severe. Coming to the Facet scoring, which has only 5 components, which is FEV1 less than 50%, age more than 70, chronic Pseudomonas colonization, extent more than 2 lobes, and dyspnea of MMRC more than 3. So what these scores actually tells us is, with the increasing score, the mortality in these patients are severely affected, and it can be up to 25% if the score is in the severe category. Coming to the microbiology of bronchiectasis, chronic bacterial colonization is present up to 60 to 80% of patients and drives inflammation and progression. The common organisms which are isolated are Haemophilus influenza in 47% of patients, Pseudomonas in 12 to 25%, Moraxella cattalis in 10%, Staphylococcus aureus in 8%, non-tuberculous mycobacteria, especially MAC and Mycobacterium abscessus, and the incidence varies, and Streptococcus pneumonia in approximately 7%. So it is very important to actually consider pneumococcal vaccination in this subset of patients. Coming to the very vital and the crucial part of bronchiectasis management, which is the airway clearance techniques. ACT is the cornerstone of bronchiectasis self-management, which is recommended daily, guided by a specialist physiotherapist. The active cycle of breathing, which is ACBT, which has breathing control, thoracic expansion exercises, forced expiratory huff, widely used, no device needed, and has a grade A evidence in good outcome. The next one is autogenic drainage, which is a self-drainage using controlled breathing at different lung volumes. High technique demand, which is most effective in CF, and there is a grade B evidence in this group. The oscillating PEP devices, which we usually find in the day-to-day practices where patients carry one small equipment in their handbag or a pocket, like Flutter, Acapella, Aerobica, which combines PEP with oscillations to loosen mucus, which is well tolerated and it's found to have grade A evidence. High frequency chest wall oscillation, HFCWO, which is a mechanical vest, which is an alternative when other ACT not feasible, useful for neuromuscular patients, especially with grade B evidence. Postural drainage, position-dependent gravity drainage, adjuvant to ACBT or AD, avoid in GERD, hemoptysis, and head injury patients, and it can be done in patients who are hospitalized for bronchiectasis without hemoptysis. Exercise, aerobic and inspiratory muscle training improves mucociliary clearance, exercise tolerance, and quality of life, which has grade A evidence. Mucoactive and mucolytic therapy, again, one of the most important cornerstone therapy for bronchiectatic patients. Hypertonic saline, 7% recommended grade A evidence. Inhaled hypertonic saline improves mucociliary clearances, reduces exacerbations. Start 3 ml twice daily via nebulizer. Pre-treat with bronchodilators. Main side effects is bronchospasm. Mannitol is an alternative. Dornase alpha can be used, not recommended in non-CF patients. Erdostin and N-acetylcysteine, insufficient evidence. Carbocystin, considered in selected group. Oral mucolytic used in some European centers, reduces sputum viscosity. No large RCT in bronchiectasis, may benefit in elderly patients. Coming to the bronchodilator and anti-inflammatory therapy, short-acting bronchodilators like SABA and SAMA, used before ACT to improve sputum clearance. ACT is again airway clearance techniques, and no RCT evidence for routine use in bronchiectasis. Indicated irreversible airflow obstruction demonstrated on spirometry. Lava-lama, considered if concurrent COPD or asthma is considered, common in 30 to 70% of patients. Tiotropium, salmeterol, formoterol can be used, shown to improve FEV1 and quality of life in COPD bronchiectasis overlap. Not routinely recommended without obstructive physiology. Inhaled corticosteroids, evidence weak in non-CF bronchiectasis. Embrace trial, ICS did not reduce exacerbation. Use only if concurrent asthma or eosinophilic airway disease has been documented. You can use pheno as your guide. Associated with increased risk of NTM, and use it with caution. Macrolide anti-inflammatory effect. Azithromycin or erythromycin at low dose has immunomodulatory effect, which reduces the IL-8 and neutrophilic influx, distinct from antibiotic role. 3 landmark trials, BAT, Embrace, UK, and BLESS, demonstrated reduced exacerbation frequency in the macrolide long-term therapy. So what are the regimens used? The BAT used azithromycin 250 mg per day versus placebo, which reduced the exacerbation by 66%. FE1 was preserved, but macrolide resistance increased. BLESS trial used erythromycin 400 mg BD versus placebo. Exacerbations reduced per year reduced by 0.97. Sputum volume reduced. H influenza resistance also increased. The Embrace azithromycin 250 mg 3 times a week. Exacerbation-free survival increased to 80%. Quality of life improved. The Columbus study, azithromycin mild disease, no benefit in low severity patient target. So before starting a patient on macrolide therapy, make sure there is a screening ECG where the QT prolongation is more than 450. You have to avoid it. Exclude active NTM before starting. Annual hearing test, sensory neural hearing loss risk is high with long-term macrolide therapy. Monitor LFTs and macrolide resistance patterns. Duration is usually 12 months and reassess annually. Coming to inhaled antibiotic therapy, the targeted for chronic Pseudomonas aeruginosa colonization with more than 3 exacerbations per year achieves high local concentration with minimal systemic toxicity. So cholestyramine. So the dose here is 125 mg BD or 1 million units BD via nebulization. The fresh and orbit trial shows significant bacterial density is lowered and trend to fewer exacerbation. Azithromycin lysinate. The Azili trials showed increased quality of life. FE1 is preserved and density is reduced. You are approved for CF and off-label for non-CF. Tobramycin, the dose is 300 mg BD for 28 days on and 28 days off. CF-derived evidence, non-CF, decreased density, limited exacerbation data. Liposomal ciprofloxacin, 590 mg OD, 28 days on and off. The Orbit 3 and 4, phase 3 and 4 showed decreased exacerbation frequency. EMA approved 2019, then withdrawn, which is a pipeline agent. So what will you do when there is an acute exacerbation? Let's first go with the definition and assessment. As per the ERS 2017, worsening of more than 3 symptoms for 48 hours and warranting change in treatment is considered to be a bronchiectasis exacerbation. The symptom criteria includes increased cough frequency, change in sputum volume and purulence, worsening dyspnea, new or worsening fatigue and malaise, hemoptysis, and fever more than 38%. New or worsening radiological changes. Assessment: do a sputum microbiology, culture and sensitivity, bloods, chest X-ray to rule out new infection and pneumothorax, spirometry, baseline deviation from personal best, oxygen saturation should be monitored, severity markers like PSI and CURB65 if pneumonia is suspected. Antibiotic treatment during exacerbation: no Pseudomonas aeruginosa, mild to moderate exacerbation guided by prior sputum culture and sensitivities, or empirically start amoxicillin 500 mg to 1 gram TDS per oral for 14 days, alternative doxycycline 100 mg BD or coamoxiclav 625 TDS for 14 days. Severe or hospitalized, no Pseudomonas aeruginosa colonization, duration 14 days, de-escalate as per culture. IV amoxicillin, clavulanate or cephalosporin, ceftriaxone 1 to 2 gram OD, switch to oral when CRP falls more than 50%. Chronic Pseudomonas aeruginosa colonization, mild to moderate, oral ciprofloxacin 500 to 750 mg BD, alternative levofloxacin 750 mg OD if susceptible. Chronic Pseudomonas aeruginosa, severe and hospitalized, therapeutic drug monitoring is essential for aminoglycoside. IV anti-pseudomonal beta-lactam like piperazine, tazobactam, ceftazidime or meropenem can be considered, plus or minus aminoglycosides, gentamicin considered therapeutic drug level monitoring. MRSA is suspected. IV vancomycin or linezolid, teicoplanin can be also be considered as a once daily alternative. So what are the hospitalization criteria and indications for the IV therapy? The marked increase in dyspnea, hemoptysis more than 10 ml or massive hemoptysis, failure for oral antibiotic, systemic features like fever, rigors, hypotension and altered consciousness, significant comorbidities like heart failure or renal impairment, and no new radiological changes, especially pneumonia, empyema, and pneumothorax, warranting admission. Coming to the final few slides, Pseudomonas aeruginosa eradication strategy. First line, ciprofloxacin 750 mg BD, 3 weeks, plus or minus cholestyramine inhaled 1 million unit TDS for 3 weeks. Second line, IV ceftazidime or piperazine tazobactam with IV tobramycin for 2 weeks in patient, then oral step down. After eradication, repeat sputum culture at 4 weeks, 3 months, 6 months. If negative at 6 months, eradication is confirmed. So you need actually a 6 months duration to prove there is an effective eradication done in patients. If there is a failure or reconciliation, consider long-term inhaled antibiotic therapy, prophylactic protocol as per BSI and FSET severity score. Biofilm formation makes chronic Pseudomonas aeruginosa extremely difficult to eradicate. Prevent persistence with prompt treatment of clinical management of bronchiectasis. Non-tuberculous mycobacteria related bronchiectasis. So positive culture more than 2 separate sputum samples, or positive ball culture or lung biopsy with compatible histopathology and CT findings in a patient with compatible symptoms, excluding other diagnosis. Most common species is Mycobacterium avium complex. MAC treatment 18 months with macrolide azithromycin or clarithromycin with rifampicin and ethambutol 3 times a week if nodal bronchiectatic form. Daily therapy for fiber cavitary and severe form. Add amikacin IV for the first 2 to 3 months in severe cases. Treat until 12 months culture negative. Mycobacterium abscesses treatment, amikacin IV plus imipenem or sulfoxetine plus or minus azithromycin for 4 to 8 weeks intensive phase. Continuation inhaled amikacin with azithromycin or oral clofazimine or linezolid. High failure rates. Consider surgery for localized diseases. So mild hemoptysis, treat the underlying infection, review anticoagulants if there is any anticoagulants in use. Moderate hospital admission, IV tranexamic acid 1 gram TDS. Bronchoscopy if there is a persisting hemoptysis, check coagulation again. Massive airway protection, intubate if needed, bleeding lung down, urgent bronchial artery embolization, surgical resection in refractory cases. So pulmonary rehabilitation is one of the most important core component of bronchiectatic treatment, which includes exercise training, inspiratory muscle training, exercise prescription, nutritional support, and psychological support. Patients on respiratory failure, oxygen and NIV, long-term oxygen therapy is considered. Target for 94 to 98% at rest, considered more than 15 hours per day. Non-invasive ventilation, if there is a hypercapnic respiratory failure, consider non-invasive ventilation. High flow nasal cannula, emerging evidence in acute exacerbation as alternative to venturi mask. Benefits, decreased work of breathing, increased comfort. Ambulatory oxygen for patients with exercise-induced desaturation. Prescribe for formal assessment, may improve exercise quality and quality of life in certain patients. Vaccination, of course, patients should be vaccinated with influenza annually. Pneumococcal PCV20, that is the latest guidelines. And other vaccines can be considered as DTaP, RSV. Hand hygiene is very important. Avoid smoking. Avoid external environmental irritants. Dental hygiene is very important in bronchiectatic patients. Eradicate Pseudomonas aeruginosa at first isolation. Immunoglobulin replacement if there is a hypogammaglobulinemia confirmed. Follow up every visit. You can do symptom review, exacerbation count and hospitalization. Review adherence to ACT and medications, SpO2 measurements. 3 to 6 monthly sputum microbiology. Update BSA and Facet score. Review inhaled device technique. Annually, you can do a spirometry, 6-minute walk test, HRCT thorax if clinical deterioration is considered. ECG if the patient is on long-term macrolide. Hearing test if the patient is on long-term macrolide. And psychological well-being scoring and quality of life can be measured with SGRQ or BHQ scoring. As indicated, blood immunoglobulins level, echocardiogram if pulmonary hypertension is suspected, sleep study if nocturnal desaturation of copper pulmonale is there, and genetic if CF and PCD is not previously assessed. So these are the few drugs which are on pipeline, like brensocatib, alvelestat, STAT3 inhibitors and JAK inhibitors, bacteriophage therapy, gene therapy, and CFTR modulators. So coming to the integrated management, bronchiectasis confirmed with HRCT, investigate etiology. All patients do airway clearance technique, vaccination, smoking cessation, nutritional support, and pulmonary rehabilitation. Assess BSI severity. If mild, then optimize ACT, hypertonic saline, monitor annually and treat exacerbation. If moderate, macrolide if more than 3 exacerbation per year. Pseudomonas aeruginosa eradication if there is a colonization proven. And 6-monthly review. If it is severe, inhaled antibiotics for Pseudomonas aeruginosa, consider NIV and LTOT as per need, and transplant evaluation has to be referred. So the summary, HRCT is a diagnostic gold standard. Do not rely on X-rays. Airway clearance therapy is the cornerstone of management. Stratify severity using BSA and FESED, and the treatment can be guided depending upon the severity score. Treat Pseudomonas aeruginosa aggressively in the first isolation. Long-term macrolide therapy before initiating, rule out non-tuberculous mycobacteria, QT prolongation, and monitor annually. Acute exacerbation require prompt antibiotic therapy guided by sputum cultures and usually for 2 weeks. Emerging therapies are DPP1 inhibitors, bacteriophage, CFTR modulators, which are already available and represent the frontier of bronchiectasis research. Thank you, and open for question and answers.
Good evening, one and all. The previous speaker has spoke very well about the medical management of bronchiectasis, and thank you CCI for this wonderful opportunity to share the surgical management and the surgical aspects of managing a bronchiectasis. So the scheme of my presentation would be it is very simple. I'm going to discuss about only 4 things which are the most important in managing a case of bronchiectasis surgically. Choosing the right patient and performing the surgery to the right extent, in the right way and in the right method. These are the 4 important things which I'm going to discuss in next 10-12 minutes. So as we all know that bronchiectasis is of heterogeneous etiology, multiple causes are there, some post-infective to the congenital causes. The primary treatment, as the previous speaker said, it is about the medical therapy and the airway clearance is the core, the concept of managing a bronchiectasis. However, surgery has a very important role in very selected patients. And it is said that the best outcomes occur when the disease is localized and when you can achieve a complete surgical resection, which is the area of the bronchiectasis. With the advancement of minimally invasive surgery, such as VATS and robotic surgery, most cases, many of such cases are being operated by such minimally invasive methods. However, because of intraoperative difficulty, if a open surgery is done, it should be taken as a very careful, thoughtful opinion rather than a failure of the surgery. So let's discuss about the first point, that is the right patient. So the indications for surgery in bronchiectasis are very, very clear. It can be of 2 types. One is a curative intent, the surgeries of curative intent. The other is the surgery of palliative intent. And the decision of surgery is majorly based on 2 factors, that is the failure of medical therapy and the extent of the disease. Very simple 2 factors will decide the patient has to undergo surgery or not. So if we broadly talk about the indications for surgical resection in bronchiectasis, there are majorly 2 indications. Number 1 is a localized bronchiectasis with persistent symptoms. Like the patient is having daily purulent sputum, recurrent exacerbations requiring admissions, and impaired quality of life despite the structured, specialized, optimized therapy the patient is on. He is meeting a specialized bronchiectasis specialist. But in spite of the best medical therapy, all these problems are happening recurrently and the disease is localized to one lobe or one lung, then the patient becomes a candidate for the surgery. Second is the complication-driven indications. Like the patient is having recurrent hemoptysis, life-threatening hemoptysis, the patient undergoes bronchial artery embolization, then also the patient continues to have this problem. And sometimes the bronchiectatic cavities develop aspergillomas, and these patients are candidates for surgical resection. I will share a few case scenarios also which are very, very important and pertinent. Like in this localized bronchiectasis, this is a 31-year-old female. The patient is having recurrent lower respiratory infections and requiring repeated admissions on the best medical therapy. So this is the perfect candidate for right middle lobectomy, and we have performed right middle lobectomy in this case and the patient is performing well. Another recent case we have performed 2 days before. This is a 22-year-old male having recurrent hemoptysis. The medical therapy was failing and the bronchial artery embolization the patient underwent twice before. And this is the patient. We performed right upper lobectomy and the patient is cured of the symptoms. And another scenario is not uncommon to see such cases where the whole lung is actually completely bronchiectatic and the opposite lung hyperinflates. And these are the patients who have recurrent infections, breathlessness, and these are the patients who can benefit from pneumonectomy surgery. So that's about the second one scenario. Now we are talking about the palliative intent surgery. This is the case with the bilateral bronchiectasis. You can see the right middle lobe involvement is there, left lingular involvement is there, and you can see the patches in the right lower lobe as well. So these are the cases, in very, very selected cases, these patients also can be benefited from the surgery. How? So these are the patients have recurrent respiratory infections and sometimes hemoptysis. So in such patients, a staged surgery can be an option. Like in this case, first we have performed right middle lobectomy and the patient is symptomatically almost 60-70% better. 60-70% better for next 2 to 3 years. And after 3 years, the patient had again developed symptoms because of the left-sided hemoptysis, and then we had to perform left lingulectomy. So this patient is now almost 90% symptom-free on medical therapy, on the prophylactic antibiotic therapy and the positional therapy, but the patient is 90% better. So surgery definitely helps in the such difficult patients also in very, very carefully selected patients. Let's see the scenario 3, that is the bilateral extensive bronchiectasis. So in such cases, many of the patients are on oxygen therapy and their lungs are failing, recurrent infections and chronic sepsis the patients will be on. And in such scenario where there is a bilateral extensive bronchiectasis, lung resection surgery is not going to help. In those patients, if the patient is on oxygen and gradually increasing the oxygen support gradually, the lung transplantation is the only option in such extensive diseases. So we have seen the localized bronchiectasis, either right middle lobe, left lower lobe, or the right upper lobe bronchiectasis, and we have seen the bilateral extensive bronchiectasis. So bronchiectasis is not a disease. It is a spectrum from localized to bilateral limited to bilateral extensive bronchiectasis. And the next question comes is what is the right extent of the disease in such patients? The core principles of managing a bronchiectasis patient surgically is to resect all clinically significant disease segments while preserving the maximum functioning lung. That is the core concept under which the most of the surgeries surgeries are done. And why important it is complete resection matters? It is a better symptom control when resection is complete and the disease is localized. If we talk about the extent of the disease can be of these 4 types. One is a wedge resection, where a small part, a non-anatomical part of the lung is resected, which is a very, very uncommon scenario that we see on regular day-to-day scenarios in bronchiectasis. Because many a times these bronchiectasis cases are either limited to a segment or limited to a lobe or limited to the whole lung. They follow an anatomical pattern. Having a wedge resection done in such patients is a very, very uncommon scenario, but yes, for theoretical purpose, we can say that. And another is a segmentectomy. So we can save the non-involved segment of a same lobe, and conventionally segmentectomy is described for malignancies, but we can extrapolate the similar concepts in bronchiectasis as well. And third is a lobectomy. So it's the most common scenario involving the lobe. The patient is having recurrent infections or hemoptysis, and do a lobectomy, the patients get better. And other scenario is the pneumonectomy, where the whole of the lung is involved, but the opposite lung is absolutely normal. So these are the patients which will benefit from the surgery. So from wedge resection to segmentectomy to lobectomy to pneumonectomy, these are the extent of surgeries depending on the clinical scenario we have to choose. And the third important thing is the right way. So we have chosen a patient and we have thought of performing a lung resection in that patient. And the third thing comes, what is the right way to perform such patients? So that's where the preoperative checklist, very, very important slide, that comes into picture. There are about 8 important preoperative checklists whenever we are planning a surgery for bronchiectasis. Number 1 is the aggressive airway clearance. It is the most important thing before you plan for a surgery, and the patient has to undergo an aggressive airway clearance before the surgery. A dedicated physiotherapist should be involved. He should be put into a program where the patient should be maximizing the sputum clearance and improve the lung mechanics before the surgery. And the second important thing is the starting the patient on culture-guided antibiotics. But many a times the patient, before coming to the surgeon, he would have met many of the pulmonologists, and multiple sputum cultures, ball cultures would have been performed, and the patient should be started on culture-based sensitive antibiotics at least 5 to 7 days before the surgery, so that the postoperative complications can be lessened. And the third thing is hemoptysis management pathway. So if the patient is having massive hemoptysis and the patient is not unstable, in those patients, it is always an option to undergo a bronchial embolization. You have that at least 1 to 2 months of buffer period. You can build up the patient and then you can perform the surgery. And of course, the important thing is the smoking cessations on the glycemic control, which is very, very important, not only in this surgery, but in every thoracic surgery. The nutritional optimization, because of the chronic infections, patients don't eat, they are catechic, and it is very important to build nutritionally in all of these patients before performing surgery. And not only the preoperative evaluation, it is also the plan for the postoperative airway clearance is also a very, very important strategy to prevent the postoperative complications. So this is how we will do the things in a right way. And the first and last important thing is the right method, how you are performing this surgery. Conventionally, open surgery is being done. It's a big cut, and the patients used to have a lot of pain. But with the increase in the use of minimal invasive surgeries like VATS and robotic, and many of such surgeries are being done by minimal invasive methods. However, if the hilum anatomy is difficult and the hilum is very, very thick, very frozen, and the calcified lymph nodes are there, the possibility of hydrogenic vessel injury during minimal invasive surgery is high. It is always better to go for an open surgery rather than pushing ourselves to do VATS and robotic surgery. It is okay if the adhesions are acceptable and the manageable hilar inflammation is there and the team is experienced. It is always better to go for VATS or robotic. However, if the hostile environment is there within the chest, it is absolutely fine to go with the open surgery. As I said before also, a conversion from minimal invasive surgery to open surgery, the threshold should be very, very low. And because the safety is more important than the method of the surgery. And because bleeding, if this happens in such patients, it can become a catastrophe. This is how we perform a lobectomy for a bronchiectasis. So this is a patient with the right lower cystic bronchiectasis. This patient is a young 24-year-old child having recurrent admissions. Almost for last 15 years, this patient is having antibiotics. In performing a lobectomy, we have to divide 3 structures. That is the vein that is going into the lobe, the arterial supply that is going into the lobe, and the bronchial supply the bronchus supply to that lobe. In this patient, we are dividing the right lower lobe vein and the right middle lobe vein. Because we are performing the right lower bilobectomy, first of all, we are dividing the middle lobe and the right-sided lower lobe veins. And then the next, because of recurrent infections, most of the lymph nodes are actually enlarged. They are inflammatory. They stuck to the blood vessels. Like in this case, the lymph node is not separable from the interlobar artery. So these patients, the lymph nodes need to be resected completely before taking the blood vessels. In this case, you can see a big node which is attached to the interlobar artery. The first step, we have removed that interlobar artery, and then the thick fissures are divided using endostaplers. And then once the fissures are divided using the endostaplers, and then the earlier we divided the posterior fissure, now we are dividing the anterior fissure. And then after division of the fissure, now you are left with the artery. You can see the artery is being looped, and then it is divided with a vascular stapler. And the last structure that is left to us is the bronchus. You can see the bronchus intermedius, where we are looping it, and we are dividing this bronchus with the endostapler. So right lower bilobectomy is done in this patient, and it's almost 3 years post-surgery. The patient is doing very, very well. And then sometimes it is not uncommon to see patients having very significant adhesions. In bronchiectasis case, it is very, very common. Because of the recurrent, prolonged previous year infections, these patients develop the pleural adhesions. Sometimes they are very flimsy, but sometimes, in many times, they are very, very vascular. Like you see in this case, this patient is a right lower lobe bronchiectasis, and you see the vascular adhesions. Almost 1.5 to 2 hours before the actual surgery, most of our efforts will be on doing an ediolysis in such cases. So this is this is how we do ediolysis in such cases. And as I said, lymph nodes are a very, very dangerous scenario. In very few of the cases, they become calcified. This is a left upper lobe bronchiectasis. We were performing the left upper lobectomy, and you see this is the calcified greasy lymph node. While we were dissecting, you can see the major tear in the left pulmonary artery. And if such thing happens during the surgery, you get maximum to maximum 1.5 to 2 minutes to save this patient. So these situations should be kept in mind while we are operating a case of bronchiectasis. And post-operative pathway very, very important. It is because the early extubation is very, very important where possible. Physiotherapy should be done and airway clearance should be done from post-operative 1. Early mobilization, pain control is of utmost importance, and antibiotics should be tailored as per the pre-op cultures. And as I said, bilateral bronchiectasis, extensive bronchiectasis on oxygen therapy, lung transplantation is the only option. This is the one of our patients we perform for bilateral bronchiectasis, the double lung transplantation. These are the explanted lungs. You can see how infected they are. So these are the lungs which are implanted to this patient. And this is the patient before the surgery, a merchant from Jalandhar, having a bilateral bronchiectasis and on 8 liters of oxygen before the surgery. We performed double lung transplantation. The patient had excellent post-operative recovery, discharged on post-op day 21, and then the patient is doing pretty well. And recently he sent us a picture. He went to Atal Rohtang Pass recently. And this is how a good surgery in a good selected patient can change their lives. So take home message, I will come to the same first slide, that is surgery in bronchiectasis is about choosing the right patient, performing the surgery to the right extent, in the right way, and following the right method. Thank you so much, CCI, for this opportunity.
So much, Dr. Koushik. Yeah, thank you so much, Dr. Koushik. You took just 20 minutes to talk about whole of the things about bronchiectasis. It's just incredible. And Dr. Mohan, it was like watching surgery live being performed by you. And I have never been so clearly be told about surgical aspects of bronchiectasis in such a short time with very clear and crisp message. So thank you so much, both of you. So Dr. Koushik, when in your talk, you gave us a comprehensive, exhaustive list of the etiology of bronchiectasis. And I believe that when we diagnose bronchiectasis, the first task that we have in our hand is to identify the etiology of the bronchiectasis. So can you tell us what minimum set of investigations you would do to know the etiology of bronchiectasis in a newly identified patient? So is Dr. Koushik there?
Yeah, thank you, Dr. Madhukar, for that very important question. So there are a few things which we actually have to understand before ordering tests for bronchiectasis. So the number one would be doing a HRCT thorax. So that would be the gold standard to see if there is a bronchiectasis in first place and confirm the diagnosis, and to see if it is a unilateral or a bilateral disease and which lobe is affected, whether it is upper lobe predominant, lower lobe predominant, or it's a middle lobe or lingular predominant. So depending on that, your initial set of investigations can begin there. And depending upon the extent of the disease as well and age of the patients as well. So that is where you actually start working upon your bronchiectasis patient's etiology. So like I discussed in my talk, so the most important thing is ruling out infections. So I would definitely rule out common infections in these patients, and also rule out tuberculosis and non-tuberculous mycobacteria. Those, when it comes to infection, that is the one. And a detailed history of childhood. So what has happened? Any insults have happened, and is there any history of previous viral illnesses? All that, any history of near drowning that would have caused any bronchiectasis in these patients. And the third important thing would be genetical testing. It depends on multiple other symptom syndromes you would like to see, and if there is any evidence of dilated bronchus, or if there is any other fertility issues, then you also think of other syndromes which are associated with bronchiectasis. So you would also like to evaluate for PCD or CF, or the genetical investigations which you can do, because CFTR gene is not widely used here. We usually go for a basic sweat chloride screening for all our bilateral cystic bronchiectatic patients. That can also be used. And few things which we actually miss out in a routine practice is evaluating the immunoglobulin level. So which is very important. We have to do a basic immunoglobulin levels in these patients, especially the IgA, IgM, and IgG, and figure out if there is any hypogammaglobulinemia which is present. And more, if the patient is asthmatic, definitely we should do a serum IgE levels, and also rule out if there is a ABPA screen, and then figure out if it is if the patient is having any tendency to have an ABPA positive or any ABPM also, that can also cause these kind of changes. Then yeah.
So in a nutshell, Dr. Koushik, if I would not be wrong if I put it like that, if in an adult patient with newly identified bronchiectasis, the minimum set of investigations that you would like to have a sputum test for microbiology, especially, NTM, tuberculosis, bacterial microbiology, and also the patient should be subjected to have ABPA panel test, and should be tested for the serum immunoglobulin.
Dr. Madhukar, so that it's not so easy to say that I will do all these tests in my newly diagnosed adult patient. That is what I was trying to tell. So it depends on what kind of picture we see the patient in total, like whether this is a patient with long-standing disease from childhood, or if this is a new onset bronchiectasis, or if there is any history of tuberculosis in the past. So things will vary. We can't put it as a thumb rule saying all your newly presenting bronchiectasis patients should undergo all these tests. So I think you can take clues from everywhere, especially from the history. Second is from your CT, HRCT thorax. I think this is where you can draw clues from and decide what has to go as the first line of investigation and what has to go the second line of investigations.
All right. Thank you so much, Dr. Koushik. Dr. Shweta, we say that no radiological pattern is suggestive or not suggestive of cystic fibrosis.
Yes.
Similarly, we miss out most of the patient with primary ciliary dyskinesia because we keep on treating the patients, labeling them as idiopathic bronchiectasis. And similarly, there are alpha antitrypsin deficiency disease where bronchiectasis does occur without a classic lower lobe involvement. So in a nutshell, the CT the CT definition of localization or the CT pattern may not be, a great idea to begin investigating the patient. So when would you suspect a patient to have a genetic underlying cause of bronchiectasis, especially in adult patients?
So as you rightly said, genetic cause is a very important cause. So when we are looking at genetic causes of bronchiectasis, we are particularly looking for whether it was cystic fibrosis, primary ciliary dyskinesias, immunodeficiency syndrome, or alpha-1 antitrypsin deficiency. So these are the basic subset of genetic disorders which may cause bronchiectasis. So when we look at the clinical parameters, we should start from the age of onset. Even the patient may present to us in adulthood, but the symptoms might have begun in childhood or the early during school days or college days, when the patient has chronic productive cough since childhood, history of recurrent respiratory tract infections and admissions for that. You should also look for the family history, whether there is a family history of bronchitis or not, family history of infertility. And then, particularly when we are looking at disorders like cystic fibrosis, then you should ask for some symptoms like whether the patient had any abdominal symptoms during childhood, pregnancy, insufficiency, any malabsorption syndromes. Male infertility should be looked in. It's a very, very important thing with cystic fibrosis because there is congenital bilateral absence of vas deferens. Then you look for the other systemic manifestations like involvement of the nasal symptoms, chronic sinusitis, nasal polyposis. When you are looking at PCD, you look for chronic rhinosinusitis, you look for chronic otitis media. There may be sinus abnormalities like sinusitis inversus. So this may be one of the important radiological signs when it may point towards PCD. Again, when you are looking at immunodeficiency syndromes, you will look at the different infections since childhood, which may be pertaining to sinus or maybe chest infections, various kinds of fungal, viral, or you may be having a particular flora which has been grown during childhood or adulthood, like pseudomonas or burkholderia, which is pertaining to cystic fibrosis or PCD. So these are also important markers. And then when we are looking at alpha-1 antitrypsin deficiency, in CT scan, you will get some emphysema-like changes along with bronchiectasis changes with or without smoking history. And radiologically, when we are looking at cystic fibrosis, maybe upper lobe predominant. PCD may involve lingular also. It may be diffuse, but sometimes it particularly involves middle lobe or the lingula. Alpha-1 antitrypsin deficiency, as I told, there may be emphysematous changes along with bronchiectasis. And you may be looking for ABPA also because it may also be a genetic. Look for the mucus plugging, the hyperattenuated mucus, or the typical bronchiectasis, the varicose bronchiectasis or the secular bronchiectasis that we typically find in ABPA patients. So these are the various clinical findings, or the history is very, very important. Like Dr. The previous speaker has also has said that you do not do all the tests at one go because we are in a resource limited setting. Whatever the ERS guidelines say that we have to do immunoglobulin this and that at one go, we cannot do that. We have patients who are coming from the village also. So you have to take the history is very, very important, and that will point you whether you are going towards the genetic causes or the acquired causes.
Yeah, that's a great point put forward, Dr. Sweta. Thank you so much. When we have done with the diagnosis of bronchiectasis, we are simultaneously evaluating the etiological, the etiology of bronchiectasis. We start gauging the severity of the bronchiectasis also. So, Dr. Aparajeet, you're here. I would like to know how do you identify high risk bronchiectasis patients, and why is it important for us in clinical practice to identify those high risk bronchiectasis patients?
So, sir, we have this bronchiectasis severity index scores, phase scores, EFACE scores. So, primarily, what do we see for the clinical flags is chronic airway colonization with pseudomonas, then patients with frequent exacerbations, then patients with severely compromised FEV1, and if the patient has multilobar disease or patients with cystic bronchiectasis, as well as if they have any comorbid cardiopulmonary complications, and if the most importantly, again, we can see if the patient's body mass index is very compromised. So these are usually how we flag the high risk groups of a bronchiectasis patient.
Yeah, that's important. But one thing that we should not miss out is if the patient has the previous history of exacerbation. If a patient has previous exacerbation history or hospitalization, that means patient is a high risk bronchiectasis patients. The rest of the things that you said, it's brilliant that all we have to understand all these things. But there are certain etiologies of bronchiectasis that put the patient's bronchiectasis in a high risk category. A patient with the initial test that we do for most of the patients with NTM infection, the patients with ABPA, this is why every patient of bronchiectasis should be subjected for the sputum NTM TB, and the patients should be subjected for ABPA test. Patients with primary immunodeficiency, these three tests are the initial test in all the patients. Why the guidelines have recommended? Because these three things are, common. Approximately 20% is the prevalence of these three etiology. Not only this, these three etiologies are also, if you are found to have in a patient of bronchiectasis, these are high risk bronchiectasis patients. Not only this, the patients with rheumatoid arthritis, patients with primary ciliary dyskinesia, and the patients with COPD bronchiectasis are all high-risk bronchiectasis patients. Why do you identify high-risk bronchiectasis patients in your clinical practice? We have identified, but what's the purpose of doing this? Why do we identify these patients and label them as high risk? So, like anyone can come up with the answer if you are willing to speak about, Okay, so Dr. Sweta, would you like to say something? Yes.
So high risk means like we need to find out the patient who may have different exacerbations in the future, because this will have a great impact on the prognosis of the patients, and we need to decide whether we need to give antibiotics, in that patients or not. So,
yeah, absolutely great answer. So, meaning thereby, we need to keep a low threshold for the treatment in these group of patients. Even if these patients have one single exacerbation in the past, they should be offered the treatment as we offer in the other patients with two or more exacerbations. And also, we tend to follow these patients, at a shorter period of interval of time rather than the standard set for the other group of bronchiectasis patients. As Dr. Mohan Venkatesh truly told us, that bronchiectasis is a complex and heterogeneous disorder, so heterogeneous that a single guideline cannot be comprehensive and cannot address each and every patient. But then we just saw the four vicious vortex of the bronchiectasis, and the medical management of the patient addresses each pillar of the vortex. So let me come to the first pillar of this vortex, that is infection. I'm talking about this at the earliest because infection is the primary driver of the progression of the bronchiectasis. And we have a microbiologist sitting with us. So, Dr. P. Swati, we often send a sputum sample from a bronchiectasis patient for the microbiological testing. Would you please tell us which sputum sample and should be an ideal sample for these patients to have a microbiological test? And how do you say that this sputum sample coming to you is an adequate sample? Dr. P. Swati, are you there?
She messaged she is having a power cut.
Okay. So we would come to her later on. So we would discuss this pillar with the microbiologist later on when she joins us. So let's come to the second pillar, and the second pillar is inflammation. Inflammation, approximately 70% of the patients with bronchiectasis will have neutrophilic inflammation. 20% of the patients will have eosinophilic inflammation. So let's come to the most common one, the neutrophilic inflammation. So, Dr. Sweta, Dr. Aparajeet. Okay, so Dr. Sweta, I'd like to know it from you. In an adult patient with bronchiectasis, should long-term macrolide be used? If yes, then what should be the appropriate screening and follow-up for those patients?
So, yes, macrolide, the long-term macrolides are indicated in bronchiectasis, but mind you, not all the patients. As you have emphasized earlier, that the patients who are having recurrent exacerbations, like more than one severe exacerbations, more than two exacerbations in the last year, or any exacerbations with increase in the symptoms. So these are the patients who are high risk. So in these high risk patients, if you have isolated pseudomonas, so this is an indication that there's a strong recommendation that you should go ahead with the macrolides if you're not giving anti-pseudomonal antibiotics. Or if you have isolated other than pseudomonas, then there is a conditional recommendation that you should go ahead with the macrolide antibiotics for a longer period, maybe 6 months to 9 months. But you have to repeat your cultures. You have to see the follow up the patients clinically and radiologically. So there should be a defined period, and you should follow up the patient at regular intervals. Another important point while giving these antibiotics, like what you said, we have to look for the adverse drug reactions. So with macrolides, you should be particularly looking for regular LFTs and kidney function tests because they might lead to liver function test. You should go with the ECGs because of the risk of QT prolongations. You should look for the drug-resistant pattern also. That's why you should keep on doing the regular cultures. And then with macrolides, there is another issue that you should always rule out the NTM, because if your culture is growing NTM and you are giving the single monotherapy with macrolides, then it might lead to other drug resistance. So these are the things we should look at. LFT, KFT is basically ECG, repeated cultures. Then one thing is hearing loss. Hearing loss, tinnitus, these are also very common side effects with macrolides that you should not miss, and you should keep monitoring the patients with these symptoms. So when you are giving the macrolide therapy, we have 2 or 3 options. Like we can give azithromycin either 250 daily or 500 milligrams twice a week, or you can give azithromycin also. And you should definitely keep following them for these following adverse drug reactions.
So, Dr. Sweta, it was just a brilliant answer. I mean, you covered almost everything, How are you going to screen them? How are you going to follow up them? What is the indication where you are going to put the macrolide for the patients of bronchiectasis? You talked about monitoring the patient on macrolide therapy. What monitoring would you do in a patient who is on macrolide therapy?
Monitoring, as I told, that for LFT, KFTs,
not the side effects. I mean,
okay.
What monitoring because you have put a patient who is on with a history of recurrent exacerbation. So those patients who are at high risk of exacerbation, you are putting the patient on macrolide.
Yes.
So it makes us important to understand that the monitoring here in patients on macrolide is the monitoring on the frequency of exacerbation. So if a patient has responded to the macrolide, means yes. So the response has to be monitored in terms
clinical, of radiological, and repeated sputum cultures.
Not radiological, but it's clinical because you are putting the patient just because the patient has high risk of exacerbation, right?
Yes.
So you have to select those patients. So monitoring should be in terms of the frequency of exacerbation. If the patient has responded to the macrolide therapy at the end of an year, the monitoring should not be short because you are looking at the frequency of exacerbation. You cannot gauge the frequency of exacerbation in 3 months or 6 months. So it's an year. So if a patient has responded in terms of reduction in frequency of exacerbation at the end of an year, then you would prolong the treatment, go on with the macrolide therapy for a long term. But if patient has not responded, you won't continue the macrolide because it's a toxic drug.
Right.
So coming to the second question, and that is addressing the eosinophilic component of the bronchiectasis, eosinophilic inflammation, which occurs in 20% of the patients with the bronchiectasis. So, Dr. Aparajeet, should long-term inhalational corticosteroid be used in adults with bronchiectasis?
So it is not usually recommended until and unless there are comorbid conditions like bronchial asthma, COPD, or ABPA.
Yep. So that's a great answer. So you would always like to see if the patient has concomitant asthma or COPD there in bronchiectasis. And if the patient has concomitant asthma and COPD, then usual guidelines for prescribing ICS in those patients should be followed. But if the bronchiectasis is alone without asthma and COPD, at present, there is no consensus to prescribe inhalational corticosteroid in those group of patients. So, Dr. P. Swati, have you joined or should I move to the another pillar? Okay, I think...
I have joined.
Oh, that's great. Swati, we just missed the first component of the VCS
Yes, sir.
vortex.
Sorry, there was a power cut suddenly. Yeah.
No issue. So we just missed out the first, the pillar of the VCS vortex, or the first component, that is the infection. And we all understand that infection is the primary driver to the progression of the bronchiectasis. So you often receive sputum samples from the patient of bronchiectasis. So what sputum sample you will advocate us to send it to you? Is it freshly expectorated, or induced sputum? Or how do you judge the adequacy of sputum sample for microbiological testing?
So here, actually, when we are receiving sputum samples, the major samples which we reject from our end are the sputum samples because of the quality of the samples we are receiving. So mostly it will be saliva mixed, or it will be food particles mixed. So that is the on macroscopic appearance, we do reject most of the samples. So when we are making a smear, we see the adequacy of the sputum sample by looking at the number of neutrophils and epithelial cells which are present in the sample. So we use something called as Bartlett scoring, where we grade, if we grade a sputum sample as a good sample if there are more than 25% of neutrophils and less than 10 polymorph epithelial cells in the sample. Secondly, we have to instruct the patient accordingly to wash his, clean his mouth before without antiseptic with water. And then he have to take a deep breath and then inhale out, preferably at the fasting stage, so that it doesn't get contaminated with food mixture or anything which can be lively in the sample. So this is how we try to grade the sputum samples, or we try to test the adequacy of the sputum sample when it comes to the labs.
Yeah, so it's a very important message from Dr. P. Swati to all of us pulmonologists, that whenever we see the report of sputum culture, we should see whether the adequacy of that sample is mentioned in it or not. And if it is not mentioned, then we should make a habit of asking our microbiologist to put first whether the sputum sample was adequate or not. So this is an important message. And Dr. P. Swati, when you see the sputum culture in bronchiectasis patients in your practice, what is the most common microorganism you encounter in a patient with bronchiectasis?
So since we work in a tertiary care, we usually get chronic patients. So my usual organism, which we have seen in case of bronchiectasis, has always been Pseudomonas. But the major challenge we face were total drug resistant or pan-drug resistant Pseudomonas, because these patients have been treated with so many antibiotics on, and they're regularly on antibiotics. Secondly is there will be lots of other organisms. We see even gram-positive cocci. So which could be like GPCs, like strep pneumonia and staph aureus. These are the second most common things which we have been usually seeing. Haemophilus influenza, you see in pediatric cases mostly, not in an adult case. So this is the common organisms we are encountering in case of bronchiectasis, which we are in our hospital setup. And secondly, we are not getting much of, because these patients are, by the time they are being, since they are regularly giving, so we don't face, inadequacy sample or, salivary sample with these cases mostly. And second most common is we are getting induced sputums or BALs also. So we are not having that commensal flora challenge very high with the bronchiectasis cases as such, compared to any other pneumonia case or, any other respiratory disease samples which we are getting.
So actually I was putting this question here, if you see the global data, we have the Haemophilus influenzae as the commonest microorganism.
And Western countries have mostly that.
So Haemophilus influenzae actually is associated with poor prognosis in bronchiectasis, like Pseudomonas aeruginosa. But why in our country, is it the difficulty of culturing Haemophilus?
Can you please repeat it, sir?
Yeah. So is it
there is the same way of culturing, sir? There is nothing, but we need to add extra media for it, which we usually do for most of the labs do it when we get a sputum sample. That is called as chocolate agar. So we need to just take an extra effort to culture it, because it's a very fragile organism and it immediately responds to antibiotics. So the cell wall is disrupted immediately. Though the infection for you clinically may not go, but for us, since the cell wall and everything is gone there, it may not multiply for us to grow in the culture. So usually we just take an extra precaution to grow it. And nowadays, since biofires and other PCRs have come up, we are advising more to go for these panels. for these
So I was
patients
going
because
on to that questions, subsequent question. So culture independent analysis of microbiota in bronchiectasis.
yes,
When
sir.
you suggest us to ask these tests to do, and so what is the and disadvantage of doing this, and how should we interpret the result of these tests in our clinical practice?
Sir, two things are there because these patients, since they're on antibiotics most of the time, they tend to be culture negative. But you might be seeing a frank purulent sputum. So here for you, we need to grow an organism which may not be able to grow by conventional cultures. So that's one reason why we suggest you go for panels. Second option is the panels. Disadvantage with panels is we really don't know whether the organism is live or it needs to be treated because he is on antibiotics all the time. So again, we'll have to have a backup culture. It's not that they are independent of culture. We always do a backup culture. And it is again up to the clinicians again that whether you have to treat that organism. Second advantage is most of these panels, especially the lower respiratory panel, which we are advising for these, will give you antibiotic resistance genes. So that is you get at least 5 genes which are most commonly expressed by Pseudomonas, which is the most common organism. So you get a better idea before culture comes on what can be you have to change your therapy or you can hold on to the same therapy. So
Yeah,
these reasons are why we suggest mostly to go for PCRs.
yeah, that's a great answer. Just one more clarification. Metagenomic next generation sequencing versus BioFire PCR.
So biofire PCR is a faster turnaround time. It can be done for a single sample. We can give you a report in 1.5 hours. That's max. We can do it. But when you go for metagenomics and next generation sequencing, we cannot be done for single samples. We have to pull the samples, and the amount of data it throws at us, and you require a very skilled bioinformatician to read the data and to pick out what is a pathogen because it reads everything which is in the sample, and this sputum sample is such a sample which is loaded with lot of commensal flora. So again, there is a challenge for us when you go for metagenomics for samples like sputum, etc. Usually, we suggest metagenomics for most sterile samples like pleural fluid or CSFs. But when you do metagenomics, one is you have to pool the samples. It's very difficult to do for single samples. And so your TAT is delayed, your treatments get delayed. Secondly is how you interpret the data. If you have a good bioinformatician who is giving you a correct organism, it will surely help.
So that's a great message, and I feel if I summarize everything, if your patient produce purulent sputum and has frequent exacerbation, but your sputum culture comes repeatedly negative, then we should go for the biofire PCR to identify the organisms. And this is where it is placed in the clinical practice. Now the result interpretation is in the hand of the pulmonologist who is seeing the patients, whether he should actually treat these microorganisms or not. This is something different debate. I won't come into that, but let's take this infection pillar further. So the question is about, you have identified a fresh isolate of Pseudomonas. The question to Aparajeet is, should eradication treatment be used for every patient with fresh isolate of Pseudomonas? Yes or no? If yes, then what is your preferred eradication regimen?
The guidelines say yes. So the first line is usually oral ciprofloxacin, 500 or 750 mg twice daily for 14 days.
Yeah.
And on the second line, or with the severity of the exacerbation of the patient, we can switch to piperacillin tazobactam or ceftazidime avibactam or meropenem.
So
Also
14 days.
for
Then
14 days. Otherwise, also we can use inhaled colistin, tobramycin.
so you will use either oral ciprofloxacin or IV anti-pseudomonal with amikacin for 2 weeks, and then you will follow it up with inhaled antibiotics, right?
Right.
So when you do an eradication treatment, how do you know at what period of time you will check your patient's sputum again to say
So,
that organism has been eradicated?
so we repeat a culture at 3 months
Yeah.
and then again at the end of 12 months.
So 3 months, 6 months, and 12 months, right?
to check for recolonization.
Fine. So if you find your culture, sputum culture being negative at 3 months, negative of 6 months, or within 1 year, if you have two culture negative at least 6 months apart, you understand your patient has been eradicated. That's a great answer, Dr. Aparajeet. So, Dr. Koushik, it has been a long time out of touch. So I'm just coming back to you. Should long-term inhaled antibiotics be used in adults with bronchiectasis? If yes, then how should it be used and with what device?
Sorry, I didn't get the long-term antibiotics or nebulized antibiotics. Like,
Should long-term inhaled antibiotics be
yeah.
used in adults with bronchiectasis? If yes, how are you going to use it and with what device?
So basically, long-term inhaled antibiotics. So I think I had a slide on that. So there are a few medications which you can consider.
Now, the first is, when are you going to use inhaled antibiotics in patients with bronchiectasis?
Yeah, so only for eradication program, long-term eradication. So chronic Pseudomonas aeruginosa colonization is the
You cannot, I'm just sorry to interrupt. We cannot eradicate, chronic Pseudomonas infection. Eradication is entirely different concept. So what we are using is inhaled antibiotics should be used when a patient has chronic Pseudomonas infection, or you call it chronic Pseudomonas colonization.
yeah.
So, well, if the patient has high risk of exacerbation despite standard therapy. So this is when we use the inhaled antibiotics. We shouldn't really confuse it with the eradication regimen. And since it is used for the colonization in those patients where there is increased risk of exacerbation, so here the response to treatment is judged not by the sputum culture, but by the reduction in the frequency of exacerbation. So this is entirely two different things. So you very well talked about all the inhaled antibiotics in your talk. What device would you prefer in your clinical practice to administer inhaled antibiotics?
So I would preferably use a vibrating mesh nebulizer. So that would be my choice.
Fine. So is there any opinion different, or is someone amongst us using different device for the inhaled antibiotics? Anyone? Or all of us are using vibrating mesh nebulizer? Or so your clinical experience with vibrating mesh nebulizer is like should be the one which should be advocated, so good that it should be advocated precisely to everyone who is listening or being
I
present at
think
this
our
session?
manufacturers actually is written according to the manufacturers as well as the antibiotics you are using. Actually, depends
Yep.
on that.
So most of the time we use vibrating mesh nebulizer for the patients with inhaled antibiotics. So that finishes the one of the pillar of the four vicious vortex. Coming to the third one, that is mucociliary apparatus damage. And we know that for mucociliary apparatus damage, the standard treatment is airway clearance therapy. So, Dr. Mohan, after your brilliant talk, I'm addressing you for the first time. So, and you also talked about in your slide, pre-surgical airway clearance therapy, how important it is. So, there are several kinds or several methods of airway clearance therapy, and the guidelines says that there is no head-to-head trial between two methods of ACT, and therefore should not be considered superior to the another. But at the same time, the guideline says that airway clearance therapy in bronchiectasis should be personalized. So how do you personalize airway clearance therapy in your patients with bronchiectasis?
So probably my answer would be very biased or maybe limited because as surgeons we in a bronchiectasis is a cases we see very limited time actually. They come to us for the surgery. Probably a week they stay with us, and once the patient is okay, usually they go back to the referral physician. So my answer would be very limited. Please bear with that. Sorry for that. And the airway clearance technique, as it is described, it is the concept is that the daily therapies they are used to clear out the and loosen the secretions, and the patients can cough it out very easily. That's the basic concept behind this. And of course, the aim of this airway clearance technique is also to increase the exercise tolerance. So there are 3 or 4 methods mainly people use. There are many, but 3 are main. First thing is the active cycle of breathing, ACBT. It is the technique that people use. It basically combines the deep breathing and breath holding exercises, and it alternates with the relaxed normal exercises and sometimes the huffing techniques to clear out the secretions from the airways. That's number 1 method of airway clearance technique, which we use in almost all cases of it is simple to use, and people can do by themselves if they're trained, if they're taught well. So this is the one technique which we use in almost every case of. And the other thing is the oscillating PEP devices like aerobica, a cappella. To be very honest, we don't use such techniques in our surgical cases because most of the patients whom we actually choose for the surgery are relatively they're in a better condition, and there is no need to use, at least in our practice, we don't use such kind of techniques in our patients. But however, it is described that these are very good techniques to clear out the secretions and loosen secretions. And the third important thing is the postural drainage technique, specifically according to the lobe that is involved. Keeping a patient in a specific position will actually, by the gravity dependent way, all the secretions can come out. Again, in our surgical cases, we don't do it because they come to us if the left lower lobe is involved. You are doing a radical removal of the left lower lobe. There is no point of postural exercises in our therapy. And the fourth, the most important thing which we use is the exercise therapy, like aerobic exercises, inspiratory muscle trainings, which basically increases the exercise tolerance from the mucociliary clearance. So, and these are the major 3 or 4 techniques of airway clearance way.
Dr. Mohan, I believe you are using almost every ACT techniques, every airway clearance techniques that we people use. So it's not that the surgical domain is different from us pulmonologists. We actually do rely on those techniques only. We just the same thing that you have told it. I would like to summarize it. If your patient has good forced expiration, that is a requisite for doing ACBT. If your patient has good forced expiration, then go for the ACBT and postural drainage that you talked about. These are complementary to each other. And then if your patient is contraindicated to undergo ACBT, or the patient is non-compliant, or his patient is not responding to ACBT, then we add some advices. You talked about oscillatory PEP. And then finally, we see if the patient has inspiratory muscle weakness. If they have the inspiratory muscle weakness, as in your cases, we also go for the inspiratory muscle strength training. And if the inspiratory muscles are not weak, then we give some kind of, for example, we sometimes in very selected patients, we use high frequency chest oscillators. So this is somehow, the practice is all the same. So Dr. Koushik, we just talked about, ACT in mucociliary apparatus damage. The guidelines suggest us to use mucoactive agents in mucoactive agents in the adult patients with bronchiectasis. And you briefly talked about these agents also. So you talked about the evidence that we have only for the hypertonic saline. And you also said that for other agents, we do not have that evidence in bronchiectasis. But we pulmonologists are using a lot of mucoactive agents other than hypertonic saline. So how do you, what is your choice of mucoactive agents depending upon the patient's comorbidities? Because in the absence of evidence, we will select the mucoactive agents based on the patient's comorbidity. So how do you make your choice?
So my first mucoactive agent would be hypertonic saline. So that would be my first agent. And then for some patients, I would also recommend starting them on N-acetylcysteine. So these are the 2 agents which I usually use for my patients. Even though the N-acetylcysteine evidence is little low, it's grade C evidence. But then I generally use only these two agents for mucoactive nebulizations.
Okay. So we
Non-CF patients, of course.
non-CF patients, right? But at this point, should we make it clear to for our audiences that we should be using mucoactive agents only when the patient is not responding to the ACT, because we do not have enough evidence to use those agents, right?
Yeah, but if the patient is going to do an ACT, if you are using a mucoactive agent prior to the ACT along with a bronchodilator, then the ACT is proven to be much more effective. So that should also be taken into account.
Okay, so anyone having any different opinion about this? Using mucoactive agents before bronchodilator, enhancing the efficacy of
Drainage.
drainage?
Yes, definitely. Another molecule is Ardostine, which is coming up. Like it has been now being marketed. Don't have personal experience, but Ardostine is
The only problem with Ardostine is like studies have not shown a good.
Yeah, that is what. There is not strong evidence.
Strong evidence, yes.
Yes, definitely.
Fine.
And
So we have,
before giving inhaled antibiotics, you should always follow protocol. That first you should nebulize the patient with a bronchodilator. Then you should give nebulized mucolytic agent if you want to. Then physiotherapy or
loosen the secretions. Then you give a ACT.
Yeah, then you go ahead with your inhaled antibiotics. So this is very
so
important.
that's a great point, practice point. Your bronchiectasis patients will be on a lot of drugs. That too will be in the nebulized form. So if you're getting a lot of nebulization, make sure that you give nebulized bronchodilators first, and then you follow it up with the patient's, ACT, and after the AC, follow up it with the mucoactive agents, then ACT, and then finally you will give the nebulized antibiotic. So let me come to the last, the pillar of the four vicious vortex, that is the structural damage. And with structural damage, there is no one better than Dr. Mohan here to talk about. Just to summarize what you talked initially, for the benefit of all of us, that what sort of candidates with a structural damage in bronchiectasis should be referred to a thoracic surgeon to undergo surgery.
Thank you, sir. So it is there are mainly, if we talk about the indications for the concept of surgery in bronchiectasis, as I said, there are mainly four. The first most core important thing is choosing a right candidate for the surgery. And broadly, there are majorly two indications of performing a surgery in a bronchiectasis case. Number one is the failure of medical therapy in a localized disease. So there are two components if you carefully see this. One is the medical therapy is no longer benefiting the patient. That's number one. And second, the disease is localized. The both factors have to be in coordinates to perform a surgery where we can benefit the patient. If we want the best of the outcomes, these two should be definitely met. And the second indication is the hemoptysis complication, which is one of the very most common issue that these bronchiectasis patients develop. The recurrent massive hemoptysis and sometimes the aspergilloma forms in a bronchiectatic cavity causes recurrent hemoptysis, and the whole of the lobe actually gets destroyed because of recurrent infections in that lobe. So these are the main indications. Last 5 years, if I could recollect, there are about 262 patients we have operated for total bronchiectasis in our setup, 262. Out of which, if we talk about the indication wise, about 160 patients are because of hemoptysis. The majority of the patients whom we operate is not because of recurrent infections, but they come to us because of hemoptysis. And of course, good number of patients are also have recurrent infections, which is leading to impaired quality of life. And these are the other things which are important. So majority are the hemoptysis. And as I said, the extent of the disease is also very important so that we can plan better the surgery. The main concept is preserve the functional lung parenchyma as far as possible. That is the basic concept. So if it mandates a lobectomy, then it's a lobectomy. If it mandates a pneumonectomy with the opposite side lung normal, then it is a pneumorectomy has to be done. And many people, in nowadays, out of 262, as I said, about 240 patients we have done by either keyhole surgery, that is either VAT surgery or robotic surgery. Only few patients, still about 22 patients, still in our setup requires open surgery because of the chronicity of the disease, dense pleural adhesions, calcified mediastinal and hilar lymph nodes, which is a significant problem in bronchiectasis cases because of many years of the problem, these patients will have this problem. But we don't take open surgery as a failure. We don't take open surgery as a failure. It is a very, very matured decision that we take. If every case we put a scope into the chest and we try to do it by VATS, in about 90% of cases, we can achieve minimal access resection. But however, if even requires an open surgery, so be it, because at the end of the day, for the long-term control of the symptoms, the most important thing is the complete resection of the surgery rather than the method of the surgery, which is important.
Great. So that's a great answer, and it should propagate very well to all of our audiences. One last thing, Dr. Mohan. Do you get enough referral for lung transplantation in patients with diffuse bilateral bronchiectasis at the verge of respiratory failure? Or do you think that a message should be given from this platform that when should we go for or when should we choose or refer the patients for transplantation in bronchiectasis?
Thank you. Thank you so much, sir. So just to answer this, I will just tell about the number of transplant candidates who were evaluated for the lung transplantation. So far, we have evaluated about 154 patients in last 2.5, 3 years for the lung transplantant candidacy, out of which about 131 patients are actually ILDs. So in India, Dr. Shweta also will agree with me, about more than 90% of the cases who come to lung transplant evaluation are ILD cases. The second most common cause, as you said, is bilateral bronchiectasis leading to respiratory failure. In our setup, we had 24 patients who actually evaluated for bilateral bronchiectasis, respiratory failure requiring lung transplantation, out of which we had operated 6 patients of such kind of patient. And the rest of the patients, because of multiple factors like financial issues, there's so many. I can't iterate everything right now, but they did not undergo surgery because of multiple factors. So out of 6 patients which we have operated, only 1 patient is cystic fibrosis. Rest 5 patients are non-cystic fibrosis related bronchiectasis. To be very honest, our first transplant patient that we have performed is actually a bilateral bronchiectasis.
Yeah.
So just start that we at our institute have done 5 because we started our program like 9 months back only. So out of that, 2 were bronchiectasis. One was post-tubercular bronchiectasis, 36-year-old, and one was cystic fibrosis. So post-TB, post-infectious bronchiectasis, young patients we do have who go into type 1 or even type 2 respiratory failure with severe PH. So these patients may need, especially the younger lots, they may go ahead with the lung transplant if they are select candidates.
Yep. So thank you so much for great insights. And I'm very happy to say that we actually finished our webinar on time. So it's 9:28, just 2 minutes left, not many questions, because I believe our panelists have already done a great job. They have left no options, no space left for many questions to come through. Though there have been a lot of audiences been sitting here in this session. I just could come to know about this. Just one question, 2 minutes left. I'll take that question. Should inhaled antibiotics be used early or only in exacerbations? Any one of you? Should inhaled antibiotics be used early or only in exacerbations?
Again, depending upon the risk of exacerbations, depending upon the past history, whether the patient has any exacerbation in the past or not. But most of the guidelines, if you are isolating Pseudomonas, I would like to treat the patient.
So a patient.
One algorithm which they can follow is they can actually do a BSI or a facet scoring, because that includes exacerbation also as a component. So if it is lying between moderate to severe, then probably that is when exactly you can start them on inhaled antibiotics. The problem here with inhaled antibiotics is the cost of the therapy, which is going to run in lakhs when you start the patient on a 28 day, 28-day tobramycin or colistin method. Yeah.
Rather than complicating it, let's make it very clear. As Dr. Sweta was talking about, if you have a chronic Pseudomonas infection, number one. Number two, if your patient is having frequent exacerbation or at the risk of exacerbation, and third, your patient should be on standard therapy. If these three things are there, then inhaled antibiotics should be used in the patients. And here, the response to the therapy is caused not by the sputum culture conversion, but by exacerbation. There is another question coming up from Maharashtra. Why DPP1 inhibitors? Okay, these are the new classes of inhibitors being used in the neutrophilic inflammatory bronchiectasis patients, exemplified by Brosic. So DPP1 inhibitors, so different efficacy across different trials. So any one of you can take this question. So it's about DPP1 inhibitors, new class of molecules. So right, so we have in August 2025, this molecule is US FDA approved for the treatment of bronchiectasis. We have different trials for the DPP1 inhibitors. One trial, we talked about phase 2 Willow trial that demonstrated good effect in terms of the improvement in terms of reduction in exacerbation frequency. And the another trial that we had, I'll just forget the mnemonic, but it was a phase 2 trial, and it also demonstrated the same. The third trial was DPP1. It was in China, where they demonstrated 60% reduction in exacerbation frequency. And the other trial that I talked about demonstrated 20 to 40%. So phase 3 was 20 to 20%, phase 2 was 40%. So there is a huge difference. 20% reduction in frequency of exacerbation. Chinese trial, 60% reduction in frequency of exacerbation. So this is a huge difference. The Chinese trial was done only in China. And the phase 3 trial that I'm talking about, which showed 20% reduction, was global trial. So it included global population, and the Chinese trial included only Chinese population. Then the subgroup analysis of the global trial was done, and it demonstrated that the efficacy of DPP1 inhibitor is higher in Asian population. And it also demonstrated an efficacy of 60% in Asian population. So if you see the Asian population, the efficacy between these two trials is not different. And it is the ethnicity which makes a huge difference between the outcome of these two trials. And so it is very, very interesting to see in our population, Indian bronchiectasis population, how the DPP1 inhibitors are going to work, because it has shown great impact in Asian populations, both in the global trial as well as in the Chinese trial. So that would be quite interesting. A very nice question. Thank you so much. So I think we have covered up all the questions. Right. So thank you so much. Thank you so much, everyone, my esteemed panelists. It was really a great time to have with all of you. I personally learned a lot, and I hope my audience must would have been benefited by your inputs. And I do believe that these kind of webinars are going to help enhance our clinical skills. Thank you, Chest Council of India. Thank you, Lupin, for providing this platform for this academic symposium. Thank you so much, everyone. Very good night.